Hey there, this is Dr. Scott Rand. We're going to talk about pre-participation in sports physicals today, period. I want to give you this information before we start doing physicals in the spring, period. Okay, what I want to do is talk about the history of the PPE real briefly. We'll talk about some of the controversies and why we do cardiac screening and that sort of thing. Talk about the history and the exam and try to talk about exactly what you're looking for as you're doing this and try to contrast it with the normal health maintenance exam. We'll describe the physical and how you do it, and then we'll talk about some of the procedures we do in mass participation physicals. There's been a long history of people being cleared to play. It falls to the doctors very commonly to do that. It started with the 40 years ago with what they called the Triple H exam. How are you doing? Listen to your heart, check you for a hernia. There wasn't any research done on this until 1992 when the first monograph was published. The third edition was published in 2005 and was widely distributed actually through a journal called The Physician in Sports Medicine. The fourth edition, which was published just a few years ago, tried to create a standardized document for screening athletes. They wanted to create a tool for research and tried to make sure that all the athletes are getting the screening that they needed. Really, none of these goals have been realized. The goal, as stated, is to promote the health and safety of the athlete in training and competition, to detect potentially life-threatening or disabling conditions, and to screen for conditions that might predispose to injury or illness. Secondarily, it's to determine general health and to provide an opportunity to initiate discussion of health-related topics. And in individual setting, it's probably possible. In the mass settings, it probably is not. But really, there's no study that's shown any effect on morbidity or mortality in sports, even with respect to cardiac screening. The exams are inconsistently delivered by providers who really don't know what they're doing. There's inconsistent follow-up of problems that are found. But the sad part is we do this to allow administrators and insurance companies to check a box to say that every athlete got a physical. But it really kind of depends on how you ask the question as far as whether or not we're making any difference. For many athletes, this is the only time that they get any interaction with a healthcare provider. Undiagnosed hypertension and vision issues really are commonly seen, and treatment can be initiated. And rarely we will find some occult musculoskeletal abnormalities like ACL tears that really weren't recognized, and then elbow and shoulder functional things like range of motion issues are things that I've commonly found on sports physicals. The current recommendations for cardiac screening are to use a 12-point AHA questionnaire, and the physical exam looking for murmurs and Marfan stigmata. In the United States, there's no current recommendation for EKG screening. Many other organizations, however, have. It's really going to be a political, not a medical decision when it happens, because there really isn't a good medical argument to say that we should do an EKG on everyone. It unfortunately gets a lot of press when a young athlete dies. The instance of sudden cardiac death really isn't known. There isn't accurate reporting, but it's felt to be possibly about 1 in 75,000 high school and college athletes, 1 in 9,000 military recruits. It's more common in men than in women, and 40% of sudden cardiac deaths occurred in the African American population, which is greater than their proportion of that participate in sports. So the African American population very definitely has an increased risk. The etiology can be either structural, electrical, or caused by other things like trauma, which is commotio cordis, some drugs, or persistent pulmonary hypertension. Hypertension is now found in 6.4% of college athletes in one 2004 study. The standard that we use in the high school athlete is the fourth report in diagnosis, evaluation, and treatment of high blood pressure in children and adolescents, and the norms for that are based on age, gender, and height. Stage 2 hypertension or findings of end organ damage mean you don't get to play until your blood pressure gets controlled. Stage 1 hypertension is reasonable to play, but they do still need to be worked up. If they have a cardiac history of exertional chest pain, exertional syncope, now with syncope, it's important to differentiate when you're talking to them about did they pass out during exercise or did they pass out after exercise. Passing out after exercise is called exercise-associated collapse, and while it may need to be evaluated, is not a huge red flag of a cardiac problem. We also ask, do they get more short of breath than their friends? Do they have irregular heartbeat or palpitations, which may be an indication for Wolff-Parkinson-White syndrome or other reasons for supraventricular tachycardia. If they've had previous cardiac testing, we also want to know what that was and why it was done. In family history, we want to know, was there a premature death before age 50? Do they have disability from heart disease? Is there any genetic diseases, things like arrhythmogenic right ventricular hypertrophy, Marfan's disease, hypertrophic cardiomyopathy, long QT syndrome? All of those things are important to know from a family history standpoint. You also want to know about SIDS, or someone who had an unexplained drowning or just woke up dead in the morning. On the physical exam, you're listening to a heart murmur, and the heart murmur you're looking for is a grade 3 out of 6 systolic murmur or greater, or any diastolic murmur. You want to palpate femoral artery at the same time you palpate the radial artery to make sure there's no coarctation of the aorta, and you look for stigmata of Marfan's syndrome. The recommendation is that you check blood pressure in the brachial artery in a seated position with the arm at the same height as the heart. So, doing all those things, can we say that we make a difference? There's a high false positive rate for EKG screening, showing a 2% disqualification rate at best. But if you have 5 million athletes, that's 100,000 of them, then they don't get to play, probably for no reason. The American Heart Association estimated a cost of over $330,000 for every athlete with significant cardiac disease, and $3.4 million of screening for every death that was prevented. Now, when you're deciding on clearance for cardiac conditions, almost everybody can do something. But what you want to know is their sport in does it have a high static component or a high dynamic component, or both? And this chart from the 36th Bethesda Conference is the reference standard to look at, see, how demanding from a cardiovascular standpoint their problems are. In 2012, there was a conference held in Seattle to come up with ways to decrease the false positive rate for EKG screening. What they came up with was these findings, these 10 different things that are seen on EKG and are felt to be completely normal in athletes. Unfortunately, they didn't define what an athlete was, and it's very possible that the 100-pound overweight band kid who's coming to get his sports physical because the UIL requires it may not actually fall into this. However, this is an expert consensus on what was normal. It also listed things that are seen as significantly abnormal. And what I want you to note here is ventricular pre-excitation and pathologic Q waves in 2 or more leads. Those very commonly can be seen, and the T-wave inversion also is fairly commonly seen in the juvenile pattern. So that's also another site of a false positive report. There's machines that we use for EKG screening called the Cardia machines. These are programmed with these criteria and read things as normal or requires more evaluation, and they've been useful for us in that setting. All right, let's move on to something other than the heart. If there's a question on the forum of, have you ever had a concussion, and have you ever been hit or had a blow to the head that caused confusion, prolonged headache, or memory problems, which is a concussion but maybe wasn't called one. You want to watch for a history of problems that increase the risk for a complicated concussion, and those are listed here: attention deficits, seizures, migraines, depression, anxiety, or other psychiatric illness, previous concussions, and learning disabilities. If you've got someone who reports a concussion, you want to ask about those things to see whether or not there's somebody that you need to do further evaluation of to make sure they're okay for a collision sport. Okay. On the concussion history, there's detailed questioning for follow-up of initial positive answers, and you want to look for any evidence of ongoing disability or someone who's had a whole bunch of concussions that they just weren't recognized. On the concussion exam, we try to do a little bit better speech, gait, and other neuro exam testing. The BEST testing is a little iffy, but it stands for Balanced Exercise Scoring System. And it's beginning to fall out of favor right now. Baseline neuropsych evals are very reasonable. You can either do a SCAT-3, which takes about 15 or 20 minutes, or a computerized impact test, which is what we put most of our athletes through. this gives you a baseline to know what their brain works like before injury, so you know what they need to get back to. All right, other things. How about seizures? Contact and collision sports are not prohibitive if their seizures are controlled. The etiology of the seizures might be important. Was it a febrile seizure that they had as a kid, or do they have an ongoing seizure disorder? You want to think about being careful to clear them for water sports if they haven't been very stable. And I look at that like you do restrictions for driving. They have to be 6 months without any seizures. Okay. How about headaches? There are a lot of different causes for headaches. You're looking for, in this setting, exertional headaches, and try to define what their trigger is. If coughing or sneezing or Valsalva tends to bring on a sudden headache, if they have a thunderclap type headache, that's always a little bit worrisome. And again, you want to ask about concussions in the past to see if that's an etiology for their headaches. Stingers and burners, which is another thing that they ask about on the form. Remember, a stinger is a transient stretch to the brachial plexus, causing the arm to feel painful and somewhat dead. Typically lasts only a few seconds to a few minutes, and in order for them to return to play, they've got to have complete strength. Repetitive stingers requires flexion and extension views of the neck or an MRI, looking for injuries to the cervical spine or ligamentous laxity. Remember, if they've got bilateral symptoms, that's not a stinger. Okay, what they're looking for there is what's called cervical cord neuropraxia, or transient quadriplegia. If someone comes in, they have, after a blow to the head or neck, they say, I was weak in my arms and legs, they need further evaluation before they go back to any kind of collision sport. You're looking for cervical spinal stenosis in that setting. All right, another general medical things. The questions are: have you ever been denied clearance or had participation restricted for any reason? Do you have any ongoing conditions like diabetes, asthma, hypertension, chronic anemia? And have you ever spent the night in the hospital, which is just another trigger for do you have any ongoing chronic medical problems that need to be looked into further? If they have diabetes, you want to ask about secondary complications and what their control is like. You want to make sure that the athlete knows their blood sugar limits for safe participation. We're not going to go into that here. Okay. Bloodborne pathogens, HIV is not a contraindication to participation. Everybody has to use universal precautions. And remember, you got to maintain athlete confidentiality if that comes up. Okay. We ask people to list all their medicines and supplements. Remember, if they said there's nothing wrong with them, but they're taking 4 different chronic medicines, that's a problem. There's some over-the-counter meds that can affect performance or increase risk for heat or hydration issues. Things that have ephedrine in them are a big deal. And you want to make sure that they're not taking something that's banned. Not an important thing in the high school area, but if you're doing NCAA or Olympic athletes, it's a big deal. All right, you want to ask about allergies. Do they have a history of anaphylaxis? And if they have, they're going to play an outdoor sport and they get anaphylactic to bee stings, you got to make sure that there's a EpiPen around for them. On surgeries, you want to make sure that they haven't had anything recently, and if they have, that they've been cleared by their surgeon, and you want to make sure that whatever surgery they had still doesn't affect their ability to play. Did they lose a paired organ? Did they have surgery to the eye or something else that would make collision sports a bad idea? Okay, and then on paired organs, are they missing a testicle or a kidney or an eye? Usually it's not a contraindication, but it's important to know and have an informed consent discussion about it, and consider equipment that protects them, most specifically eyewear. All right, quickly on infectious mono, it increases the risk for splenic rupture, and the symptoms happen 4 to 7 weeks after they were exposed, and they can go back to play at least 21 days after the onset of symptoms. Most people recommend 28 days, and they still need to be asymptomatic. Okay. Muscle cramps and heat illness is also another question that's asked. Remember, kids are more at risk than adults, even if they're properly acclimatized. Okay, for sickle cell disease, is there a personal family history of this? We didn't think this used to be a big deal, but we now know that the risk of sudden cardiac arrest goes way up in people who have sickle cell trait even. The key is to acclimatize them more gradually and make sure that you don't overstress them in a heated environment. All right, vision and eye disorders briefly. Protective eyewear decreases the risk of eye injury by over 90%, so it's a good idea for everybody to wear it if they're going to be in a sport that puts their eyes at risk, but the people that have to have it are the ones that have a vision less than 20/40 in their best eye. What that means is if they were to lose vision, they would be functionally one-eyed, so you need to protect them from that. Okay. All right, asthma problems, you want to make sure that their asthma is well controlled. And you want to determine how bad the asthma is, how many meds are they on, when were they hospitalized last, were they ever on a ventilator, do they take chronic steroids, those sort of things. All right, on your pulmonary exam, the wheezing exam may mean they're not optimally treated. And for exercise-induced bronchospasm, pre- and post-exercise PFTs are reasonable to help screen for that. High-level athletes have to have more definitive testing. And remember, if their asthma doesn't respond to simple bronchodilator treatment, it may not be asthma at all. It may be more what's called vocal cord dysfunction, which is another topic to talk about another day. All right, their clearance is okay as long as they're not having an acute severe attack, and recommend that they have their inhaler available if they do have asthma. All right, asking the GI or GU system, you want to ask if they have a painful bulge in their groin. You want to examine the abdomen with the patient lying down. The male GU exam is really recommended, looking for the presence more of both testicles. And you want to palpate for a hernia if they're symptomatic, but remember, a hernia by itself is not a disqualifying problem. If they've got an undiagnosed undescended testicle, you want to make sure they get referred appropriately. On skin conditions, it's really just looking for infectious disease things. There's some medicines you use that can affect their participation, like tetracyclines and sulfameds and Accutane, which can give a lot of muscle pain. If somebody's just getting started in a sport and they're going to be having muscle pain just from new activity, they need to understand it's probably going to be worse than normal because of the Accutane. So it's, again, not a contraindication, but something to be aware of. Okay, on the musculoskeletal history and exam, you want to look for an injury that hasn't healed and increases the risk for other injury or medical problems. You want to make sure if they have to wear a brace that they're not masking injury that actually needs to be treated. And the physical exam really is just a simple screen unless their history dictates that they need a more focused exam. And in here is where I look for the Marfan's stigmata. Okay. In general, sprains and strains, you want to look for a symmetric range of motion. They have to have strength that's 90% of the contralateral side and no instability on your exam. For fractures, you want to depends on where the fracture is and what the risks are. Sometimes you can play with a cast, and league rules may kind of dictate that. We still check for scoliosis, although I'm not really sure why. It's not a limiting thing and actually is recommended it not be looked for. Okay. There's some more questions on the form that they try to get them to ask separately from their parents. Stress and depression, safety, smoking, alcohol, anabolic steroids, and disordered eating are the things you try to explore. And you try to ask those questions away from parents. All right, female athlete triad briefly. Remember, these kids or these people are more at risk for disordered eating and osteoporosis. It can happen in males, but it's much, much more rare. They may be more at risk for concussion injury. Infrequent menstruation is often considered normal by athletes, but remember, if they say I've only had 3 periods this year, you need to ask, why is that? Is there a problem going on? If it's because they say they're exercising too much, it's really a nutrition problem, not a exercise problem. Sometimes if they have a significant eating disorder, withholding their clearance can be the hammer that you can use to get them to work on their eating. Okay, in special needs athletes, you got to think about things that aren't usually present in unimpaired athletes. 15% of Down's kids have atlantoaxial instability. In order to be cleared, they must have flexion and extension views of their neck. Paralympic athletes, you need to think about pressure sores, think about the use of prosthetics, and there's a condition called autonomic dysreflexia, which again we won't get into here, but is something important to think about. All right, the station-based exam is not the preferred method for pre-participation physical. The monograph explicitly states that it should be done in the office of a physician that is familiar with the athlete and familiar with their sport. But practically speaking, doing these sports physicals is not going to stop anytime soon. It's a requirement. We understand that it's not really all that medically valuable, but it does check that box. It allows them to continue. So what we do at the first station, they have to come with their history form completed and signed by their parents, and whatever other signatures the schools require have to be done too, and they pay for their exam. In the second station, we do the typical vital sign things. They need height, weight, and blood pressure. We typically do automatic blood pressure cuffs with the student trainers or student nurses there, and if there's abnormal ones, we get them to a nurse or someone else who can do a manual blood pressure reading for them. And we check their vision. Try to get them to remember to bring their glasses to the physical, but if they don't, they don't. We ask about range of motion problems and injuries in the musculoskeletal exam station. There's a minimal functional exam that's done. Basically, I look at shoulders, do a brief scoliosis exam, try to do an extension exam as well, ask them to walk on their heels, walk on their toes, and duck walk. We have our athletic trainers typically do this. They've been very well trained to look for the abnormalities that we're looking for, and then if there's something abnormal, we ask the doctors to follow up with that. The fourth station is where they see the doctor. Your job as the doctor is to review their history and clarify any yes questions. The cardiac questions obviously are the most important ones, and there's some that are going to be answered a lot more frequently that mean nothing, like do you get tired more quickly than your friends, or do you feel stressed out than others. You want to look at their measurements. Make sure you look at their blood pressure and make sure it gets rechecked, and you get a reading that is valid. When you do your physical exam, you want to listen to the heart, both in a standing or seated and a lying position. That's a requirement. I palpate the radial and femoral pulses at the same time, and in our stations we typically defer the testicular exam and simply ask, do you have two testicles? Sometimes you have to clarify to these younger kids what a testicle actually is, but since that is the threshold that we're looking for in this situation, we just document that they stated they had two testicles if they did. So, and when you determine clearance, they can be either cleared for all sports, they can be cleared after they've had evaluation of whatever problem you found or whatever injury that needs to be rehabbed, and then if they're not cleared, it's not cleared for anything. It's not cleared for a specific thing. Not cleared for collision sports. Not cleared for weight training. Those sort of things. It's actually very rarely used. And we have a form to use that goes home to the parents to explain if they passed, yay. If they didn't pass, this is why they didn't pass and what has to happen next. Briefly on medical legal issues, remember the Good Samaritan laws do not apply. You're putting yourself out as a medical provider, and even though you're not getting paid for this and you're doing it out of the goodness of your heart, you're still a doctor, and being a Good Samaritan does not apply here. You got to protect yourself and make sure that you're not in any kind of position that could put you liable for something. The Texas Medical Board requires that you maintain a copy of the physical, and we maintain that by having a scan of the physical after it's completed before the kids check out. Methodist requires the parents to sign a piece of paper that says that no doctor-patient relationship continues after the end of the physical. I'm not sure how that helps them, but it's a requirement from their legal department. Okay, that's that basically. I hope this has been helpful for you. We will see you at the physicals. Thanks.